Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Oksana. How are you doing today?
Thank you, Dennis. I'm glad to see you. Thank you for invitation to the podcast. It's a really important point because problem field care, the actual in Ukraine as I never known before. Um, so can I start?
Well, just hold on a second. If you would, Oksana, would you please just do a quick introduction of yourself?
I am head of NGO Alien Training Center and sonographer, surgeon, and fellow of American College of Surgery.
Okay, very good, very good. So you're definitely the perfect person to talk to. And we're going to cover ultrasound assessment for triage and surgery. If you wouldn't mind, you can start your presentation.
Okay. Thank you. Today, I'll try to show you something new in point of care ultrasound for combat abdominal trauma. And combat abdominal trauma and emergency ultrasound when fast is not enough. Emergency ultrasound, why it's so important, why we use it so widely in Ukraine now, because ultrasound is available anytime and anywhere at the point of the collection of casualty, at the forward surgical group, for all one, for all two. In any place you can use it. It's repeatable, it's portable, it's safe, and does depend on electricity, internet, and water supply, and other things that can have some difficulties in Ukraine. EFAST is really golden standard for emergency trauma diagnosis. Very sensitive and specific for abdominal bleeding. And actually, diagnosis and stop bleeding made task for all two and for all one. And why? EFAST is not enough. It's beautiful, it's great, it's necessary, it's the best of the best protocols for diagnosis in abdominal bleeding. But the war in Ukraine, it's a new type of war. It's a little bit different that we see used to. The predominance of missiles, weapons, and drones, expensive projectile, huge range of front line, disruption of logistics way and limited resources, long evacuation time, and big number of strikes on civilian infrastructure and areas located far from war zone. As a result of this, we can see some features of combat trauma that we can't ignore. We can see the most severe associated injuries, increasing number of colon wounds, increasing number of retroperitoneal injuries. And these injuries, if we don't diagnose it in time, uh, as an outcome have a high risk of complication and high risk of mortality. For avoid this situation, especially to the colon injury and retroperitoneal hematomas, which is used to as a blind spot for standard EFAST protocol, we cannot see it in standard EFAST protocol. It was necessary to make something new, to develop a new protocol, to find a new ways for diagnosis. Because in the role one, in the role two, we have no other options than ultrasound, portable ultrasound machine. Colon injuries. As for example, colon injured with colon injury, very small. You can see the mass part of such injuries is very small without perforation. It can be penetrating wound, it can be behind armor, blunt trauma, but we can see such small colon injuries without perforation. It's very difficult to diagnose with other tools. We can no see any gas, any fluid in abdomen, but when we will be operated, these injuries when the injury will have the clinical manifestation at 3 days, 5 days after injury, we will have a septic condition, a very poor prognosis for this injured person. Another one example, colon injuries, but pay attention here. This entrance hole is on the chest, not on the abdomen, on the chest. It's another one problem. The location injured part so far from entrance hole. When you can see hole on the chest, you don't think about colon injury. But now we should to think about this. So colon injury, it's a main part now. It's a big number of small injuries, grade 1 or grade 2 to AST. This is more than half. Equipped with injuries of retroperitoneal part of colon, very complicated for diagnosis. Big distance between entrance hole and injured part, and low sensitivity and specific for EFAST, less than 30% with high mortality and high rate of complication. This is, for example, a complication of injured colon. This is the retroperitoneal phlegmona. This is the destroyed part of colon injury. This is another one, retroperitoneal injuries, but not colon. It's broken spleen. But I think so. Standard fast was normal, negative, but kidney is totally broken. Another one, retroperitoneal injuries. So why retroperitoneal injuries is next so important point? Because it's related with high blood loss, because retroperitoneum can contain a huge amount of blood. It is a common reason of clinical instability, especially during the evacuation. And another one important point is related with infection complication, especially in combination with colon injury. It's very difficult. So when I received the first request to make the ultrasound diagnosis of colon injury, make it easy, made it accessible for combat medic, for all doctors who need to make such diagnosis. The first my answer was it's impossible because the colon is really difficult for visualization. But I think everything is possible if we will try another one time, and we will try. We start the research. We start to find some ultrasound signs of future that can to help us. And in one day, it was May 19, 2022, we pay attention on very important thing that the colon where it's injured, it's spastic. It's spastic, and it very well can see in ultrasound, especially in terminal parts of colon, like a second dome and like a sigmoid colon. And it's very easy for evaluation because points for assessment is right lower quadrant and left lower quadrant. We have no other big structure that can close colon for us, or they can mm, be a reason of mistake. And we have detect the spasm and we start research. The first, it was case series. We analyzed the injured who have penetration conscious abdominal trauma and assessed the diameter of second dome or sigmoid colon with ultrasound and with next verification of colon damage intraoperative during the laparotomy or on the CT scan if it was possible. And we receive the next data that in average sigmoid colon diameter is 22 millimeters when the person is injured, you have injured colon. Second diameter 34 millimeters. But when the colon is not damaged, it's this numbers more and more. It's 37 millimeters for sigmoid and 52 for second colon. And this is significant. This is significant and it is a good ability to make timely diagnosis. So as a number, we make the 20 millimeters for sigmoid colon and 40 millimeters for second colon because it's easier for remind. So how to assess? This is the probe position and in right lower quadrant and left lower quadrant and points for assessment. You can see the second dome less than 40 millimeters and sigmoid colon less than 20 millimeters or one of them because the second react more on right colon injury, a sigmoid on left colon injury, and you can have a suspicion about colon injury and told about this suspicion the next surgeon that you can see and who will perform the operation. And another one point I have told about colon injury. This is the retroperitoneal injury and retroperitoneal hematoma. No, I will not stop on the main retroperitoneal hematoma signs. It's not something new. It's described before in literature, but I don't know why it's not used widely, because it's not difficult to pay attention and see, because the retroperitoneal space is the same blood like in the abdomen, like in the Morrison push. For assessment of retroperitoneal hematoma, we don't need new position. We can see the retroperitoneal space from first and to standard fast position, right upper quadrant, left upper quadrant, and from pelvic position. This is the pelvic part of retroperitoneal space. So what we received as results? We bring eFast protocol. It's a really perfect and the best tool for timely diagnosis. We add some points for colon assessment and retroperitoneal hematoma assessment. We received fast Q protocol. When we named it the first, it wasn't Ukrainian. It was like updated, but the main reason to add U was the shape of colon, like Latin U, and we add this U to our fast. But when I presented it, the like succeed time in Canada, it was fast Ukrainian, because it's the honorable name of our brave country, and I'd like to sing this name here in my protocol. Uh, uh, Algorithm. So if this position is not right, it have to placed in like this one, but symmetrically to 6, but I don't know what it's changed in my presentation. Algorithm the same, like the fast protocol. Uh, here is without launch position for more large focus on abdomen, but we have two additional position, lower quadrant and right lower quadrant for assessment of injured colon. It's not at a huge time or the more than 1 minute time to general fast assessment, but can provide a lot of information. After this, we had a verification of protocol, and we performed near of 1,000 fast Q protocols and compare mortality rate of complication, and received significant decreasing, and the sensitivity of fast Q protocol to intra-abdominal injuries is better than the standard TFAST. And I think so it can be useful not only for combat zone or for combat time. It can be useful for low-cost healthcare facilities who haven't possibility to perform the CT scans, for example. It can be useful for no-combat trauma, because the injured who receive injury in car accident, for example, or in other way, can have the same problem in the abdomen, and timely detection of colon injury can save a lot of life, I think. But like an example, I'd like to show a few cases, my lovely cases about fast protocol. Thank you. And the first injured received a lot of small shrapnels injured of abdominal wall, but we don't was sure that is penetrated injuries or no. Primary fast was absolutely negative. No free air, no free fluid in abdomen. But when I assessed right lower quadrant, I pay attention on this second colon is very spastic, like to zero diameter. And when we go to laparotomy, we have seen such situation. The big number of small like burns from the shrapnel without perforation, but it will be perforated at few next day if we don't operate. And operate this injured is the first day is much better than operated in 3 days, in 5 days later. So it's very well to detect it in time. Another one injury with a big penetrating abdominal injury with broken spleen, and it's very often mistake when we can see the bleeding or big bleeding inside the abdomen. We focused and don't pay attention to other injuries. Sometimes it's not right idea. We have to know and we have to do something with it. So we pay attention on the sigmoid colon very spastic. And when the surgeons go to the operation room, I called him, "Hey guys, you have paid attention on colon. I think so. This injured have some problem with it." And this is the small hematomas on difficult for diagnosis part of sigmoid colon, understanding colon, and it's very well to pay attention in time before septic condition for this injury. This is retroperitoneal hematoma. Big retroperitoneal hematoma, really not difficult for detection on ultrasound. This is the intra-operation photo of this. This is my lovely case, really my lovely. Injured head, a shrapnel like named in Ukraine like flechetta, look like an tip of arrow inside the body. We can see this is a shrapnel on the X-ray, but don't see any other things of injury, any fluid, any free gas, like just flechetta inside the body and a small collection of free gas, but not significant. And I turn on my ultrasound probe and go to the right lower corner and see such situation like here with spastic colon with shadowing from the foreign body. And we start from the laparoscopy. And here we can see the second colon. You can see the part of this flechetta outside the second colon and part both inside the second colon. And he closed the own hole. And without removing it will be a septic condition, but we avoid it and we make a decision in time, not easy decision. We provide a lot of trainings from the start of war. We trained near of 5,000 person. This is a combat medic, this is a surgeons, this is a row 1, row 2, row 3, everything, everybody who need ultrasound training can receive this training on Ellen Training Center. And another one important point, this is the support of Charity Foundation, Razum for Ukraine, who provide the portable ultrasound devices, because it's not enough to know if for to do protocol, you need a tool. And it's a lot of thanks to Charity Foundation possibility to provide these courses to support of us with the ultrasound probes and devices. And their slogan is "Together we are Ukraine." This is true. Together, all this team, it's really a big friend of Ukraine. This is our trainings, and this is my most great achievement in the mobile hospitals. And before the end of my presentation, a little reminder. This is picture taken in Mariupol hospital. This hospital is destroyed of a Russian missile in Mariupol is totally broken. I had a lot of friends. I had a lot of colleagues in this hospital. It was first hospital where I, before the big war, performed my first point of care ultrasound training. And a lot of people die. A lot of my friends die in this hospital. Doctors have not been captive as an any person. We have not died. We can to give this world a lot of interesting, lot of cool things, and we for have ability to do this. We have to be alive. So you can help us. We can support us, please, and you will receive, I think, a lot of interesting from Ukraine to other world. It's some scientific conclusion, and think so. The main point that I can focus at the end of my presentation, uh, ultrasound is very useful device. You can use widely the standard protocol. We can develop this protocol. So, train your stuff. Understand with Ukraine. Thank you for your attention. And I will happy to hear your question and answer.
Hey, very good. So, first couple questions. Could we go back to one of the slides that have the retroperitoneal space?
Okay. One moment.
Either Morrison's pouch or...
I hope that my presentation will be work correctly, but don't want. I restart another one time. Sorry.
So While that's going, um, what I'm asking for is when you get your view, like I'm used to getting, Morrison's pouch, scanning through the entire organ. In order to see the retroperitoneal space, what else should I be looking for?
Зрозуміло питання. Якщо можеш, то переклади.
М, Робиш там і фаст, ти дивишся на Morrison's pouch,
Ха.
на ретроперитоніл, чи там десь інше треба шукати, як ти там знайдеш ці
Мгм. Okay. What is the signs of retroperitoneal injuries?
може
Ага.
помити на
The first and very important one, you have to see a little bit deeper. It's used to for ultrasound specialist. Before this podcast, I was in University of Florida, and I received the same questions from the ultrasound specialist, and we had little maybe half hour workshop, and they understood really clearly how to see retroperitoneal hematoma. It used to we don't see show deeper than kidney. Oh, this is a kidney, everything is good, but around the kidney is something not accessible for ultrasound. It's not true. With a peritoneal hematoma, it's not the black hole like in free fluid intra-abdomen, but it is inhomogeneous. It is hypoechogenic part that we can in compare of psoas muscle we can very well differentiate, like here black or light black or dark gray stripe near of the psoas muscle. The next one, the dorsal enchasment. And all of us know about spine bone symptom, but we use it for hydrothorax assessment. But the same thing we can see when the person is have the retroperitoneal hematoma, because the hematoma is the blood, it's a fluid, not so good for visualization, but with the same physical features. So if you see the spine bone very well, if you see the separate vertebrae very well, especially for person who is a little bit big, it's very significant, especially when you don't see the whole spine bone, just a separate vertebrae like a tooth, like here. Here is a inhomogeneous hematoma near of kidney. Here of kidney. Here is kidney. Here is hematoma. Here is a few vertebrae. One, two, three. We don't see all spine bone. We see only a part of spine, but it's a very important spine. One vertebra, two vertebra, three vertebra, and here is inhomogeneous hematoma. Oh, sorry.
That's okay. So essentially, it doesn't matter how much of the spine you can actually see. It's just that you can see the vertebrae, the vertebral, the spaces, the disc
Yes.
spaces. That's
Yes.
what tells you. Does it?
Yes.
The more you see, the worse the hematoma is, or is it just yes or no?
In a big number of situation, yes. If you can see the three vertebrae, it's the worst situation. Then you can see only one vertebra. Like here, we can see the few hypoechogenic parts here and here. We can see two vertebrae, one and another one. And here is actually very interesting kidney. Look like usual kidney, but not usual kidney. Yeah, we given a name for this kidney in Florida. It will be underwater kidney. Why underwater? Because this is hypoechogenic. Then you can see around. This is the not kidney parenchyma. This is the water around the kidney. But kidney you can see here like a totally white. Why it's totally white? Because the dorsal enchasment work here like in this area and in related with enchasment we see the kidney like totally white. This is the underwater kidney. Very well terms from Florida University. I will use it, and I will show you another one like here. retroperitoneal space. Here is inhomogeneous hematoma, big like I don't see that they're actually hypoechogenic. It look like isoechogenic. Big part who moved and kidney. It's another one important point. You can pay attention kidney because kidney don't will be moved on the psoas muscle, for example, but hematoma will be moved. And you can see the anechogenic stripe here. So it's a little bit small image, but we can pay attention to it here and here. And can see the vertebrae. One and another one. Another one important point.
Okay, very good. Could
Yes.
we move on to a picture of either the sigmoid or the cecum?
Okay.
Are we measuring outside diameter, inside diameter?
I will measure the from outside to outside wall. Here is a measurement, but I'm not sure that this images is really right. But this here is a 1.5 centimeter length. It's really small for colon. Uh, Here I don't have a caliper on my slide, but you can pay attention on the measurement here and not more than 2 centimeters is the second column. But I think so. I have to include such slides in my presentation. It's my 10th presentation, but don't bring for today.
That's okay. That's okay. I mean, I think this is probably the most important part is getting somebody who is an expert at doing this, explain how to do it. Are you looking for any aspect of either the cecum or the sigmoid colon in order to measure, or just, horizontally, vertically?
Okay, very good question. I'd like to find my first slide is injured colon. Sometimes it's not easy to see colon, and especially difficult to see a normal colon because the normal colon is full of gas. And you have to pay attention at the wall of colon, what is closer to the abdominal wall. As used to, you can see a gas artifact looks like a fish scale or fish skin with a lot of reverberation from the air bulbs, like here. One and one and another one. Here is not a lot of such fish scale because it's an injured colon. But if colon will be not injured, you will see a lot. The more complicated or more difficult to see another one wall who is what is deeper or far from the abdominal wall. You can press, but press doesn't because when you will press intensive, you can close the colon and you will not write a picture. For right picture, just like put in a little bit press, and you will see the two hyperechogenic stripes. The first stripes is with the colon, and the next stripes is with the pelvic under the colon. How to separate colon and pelvic? But sometimes you can have some questions. I see the colon or I see the pelvic. You have to move a probe like a shake, and colon will be moved with your probe, but pelvic will not move. It's most easy things for make a right diagnosis. What can be important too? Another one important point. These signs work the best from 3 to 6 hours after injury. Work good to 24 hours after injury. If you assessed more than 22 hours after injury, this signs will not correct. It will not work because we have other mechanism of abdomen autoregulation that will be open the colon. So the best time for assessment is the first time after injury, from 3 to 6 hours or to 24 hours if you can this is injured later. Don't use the signs later than in 22 hours because it's will be not correct.
That makes absolute sense. I'm going to play, I guess, kind of devil's advocate. So we have a patient who has a retroperitoneal bleed. Okay. I'm in the field. From my aspect, the patient's blood pressure is low. He's a trauma patient. I'm going to assume he's in hemorrhagic shock. I'm going to keep sending blood until I get him resuscitated. We're using this ultrasound assessment to determine where he goes. Whether he's going to the roll 2 where they have more blood and more resuscitation, or he goes to another facility, right?
I think so. Oh, sorry.
That's okay. What will this new, the Fast U, what will that gain me that my vital signs and just my normal assessments won't?
Thank you for your question. The first one, if you will talk about retroperitoneal hematoma separate, like this case, uh, we can see the some fluid collection in retroperitoneal space. The first, the second one, we can see the dynamic because sometimes the injured people with big collection of blood can have a not bright clinical situation. This can be without hypertension. They can be stable to the terminal broke of blood pressure and death. So I think so. Fast you it this make this assessment more accurately and provide possibility to make more right decision. If we can see the retroperitoneal hematoma and patient is stable and this hematoma don't get larger and larger, the important is when you can see additional 1 centimeter in 1 hour. It's significant. If you can see, for example, 2 millimeters in 1 hour, you can evacuate it for ulcer, for example. If you can see that hematoma been larger, but patient is stable, I think so will be better to evacuate this injury to next facility where the surgical care can perform. For example, forward surgical team or stabilization point if they have possibility to stop the bleeding. Uh, it's my opinion, and sometimes guys from the roll one who wasn't my course use this tool and receive very good results. That we had it was a very interesting story. We had a patient injured who come to hospital from the 1.5 day after injury, and he was evacuated last from the casualty collection point. But when we opened the abdomen, we have seen a lot of coagulated blood and absolutely broken spleen. But he was stable to the moment of open of abdomen. He was stable in the accident and emergency department and all steps. But when he go into operation room and we open his abdomen, he broke its blood pressure. It was absolutely critical. But chances to die, it was more in the all of this 1.5 day. And if the combat medics had an ultrasound, it was all possibility to avoid this situation and evacuate this injured at first, not last at first, because for clinical signatures it was absolutely stable. It was with good blood pressure and good condition, but situation inside sometimes can be a little bit worse than we can to see outside. And have another one possibility to see inside, not only assess but see and directly see. It's important too, important possibility.
Yeah, absolutely. Another aspect, at least I've found with just the normal FAST exam, it's very good at ruling in. It's not very good at ruling out. because everything depends on the skill of the operator. So you mentioned training medics, training providers at Role 2, et cetera, et cetera. I guess how effective have they been at appropriately triaging the patients that they've received? If I can just give you an example, like, we're looking for a hemothorax and we're doing our lung slide. If you don't see any lung slide, like, for certain they have a problem in the chest and we can drain it. Where the tricky part comes in is I do see lung slide, but there's still a problem, and me using that ultrasound assessment to determine what do I do the procedure or do I not do the procedure. Does that make sense?
Можу тебе попросити це реквести. Він каже, що в роль 2 є люди, що роблять екзамен на легень, і вони мають window, і є добре, щоб сказати rule in, що щось там є, але не є добре сказати там нема. Так. І як ти так вважаєш?
Okay, I understand. It's not easy question, but very interesting. They're related with sensitivity and specificity of protocol. Really, if we will talk about first protocol, if we see the constricted or spastic colon in the most part of situation, it's related with its injury. And it's either for make assessment and make a decision. If we see the not spastic colon or don't see colon properly, it's most difficult situation because we can told that injured person have no colon injury. It's not related with that real colon condition. It's related only with operator who can't see the colon properly and miss this injury. It can be, and for avoid this situation, we have every 1 week we have like update for doctors who was at my course, doctors and combat medics, and I have to access to their scans. And if I see the not proper scan, I give a feedback that, hey, hi, your scan is not good. Maybe I have to told you another one time how to assess colon. And it's very well for them because 2 days course or 3 days course is really short. We try to achieve a good education quality. We control education quality, but sometimes they need follow up. And it's normal. I think so. It's normal situation. Um, I think so. People with ultrasound probe detect more colon injuries than people without ultrasound probe. So we continue to provide the skills and knowledge for them, but sometimes it's a little bit challenging that we have some problems that you described because all of them have different background. All of them have different skills, and they can see something situation like, I don't know, I will show you, like this one. It's very easy to see, but when we can the picture is not so clear, it can be area for mistake. But I don't see the huge number of mistake. But time to time, it happens.
Yeah, well, I mean, of course, and it happens literally anywhere on the planet. I'm not so concerned about the guy who didn't really have retroperitoneal hematoma, or he didn't have a abdominal perforation. I'm worried about the other side, that I see a normal size or near normal size colon on ultrasound, or I think I do anyway, and I don't evacuate that guy. I evacuate somebody else. Does that make sense? That's the guy I'm worried about.
If we don't see any other signs of injury, like bleeding, and so on and so forth, and injury is stable without some hemodynamic disorders or something like this, I think that will be a right decision, especially if we have another guy who had all of these things. But we haven't to forget about other injuries, like a limb injury, like a traumatic brain injury. And I have another one protocol, Trident protocol. I presented it on first time on the last week, and I think so it will be a topic for separate talk, because this protocol included not only FAST-U, included the traumatic brain injury assessment and traumatic limb assessment, and cover the most common reasons of injury, or most part of injured areas. And we have, of course, take into attention all of these factors, and it's related with each situation and each stabilization point or casualty collection point.
Well, I definitely look forward to talking with you about that.
Мені з тобою поговорити не змагаюся.
Oh, okay. Okay. And it will be very well to talk about Trident protocol and about combat medic education, because it's very under-evaluated part of medical community. It was very difficult to prove to other doctors, to other medics, that it's possible to train them, to provide them tools they really need, not only for oneself, to save somebody's life. And I'd like to pay attention of medical community on this very important part of community. It's not some like technical stuff. It's people who do a lot, and I'd like to provide all help, all support which these guys really need. And I will be happy to talk about it with you another one time.
Nice, nice. Is there any other aspects of FAST-U that you'd like to put out?
Є щось інше про цей протокол FAST-U, що хочеш поговорити про щось?
I think so. It was most important point. I don't add anything except glory to Ukraine, and thank you for your attention.
Hey, awesome. Well, I really appreciate it, Oksana.
Thank you. It was a very big pleasure for me to talk with you, to conversate another one time about FAST-U protocol. Thank you for such possibility. It was great.
Hey, thank you. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast, out.